Bismillah ar-Rahman ar-Rahim and Assalamu alaikum. I think we have a very mixed audience over here, some very senior surgeons, and then I think there's some junior people, maybe some intermediate people as well. So I'll try to make this presentation a little bit so that everyone can enjoy it. So my task is to talk about total versus non-total arterial revascularization and outcomes. But I'm going to start with something, this is my disclosure, there are none. Let's just start at the beginning so that we make it a little bit also for the cardiologists over here. How do you manage coronary artery disease? And obviously you need to diagnose it with history and physical examination, a resting ECG, and perhaps a stress testing might help. We all learn from history, and this is what we're going to talk about at the beginning. Most of the stuff that has been done in cardiac surgery was from the previous century. And it started essentially with coronary angiography, angioplasty, then came along CT angiography, IVUS and FFR that's been talked about. What are the indications and objectives for the CABG? The CABG indications are in stable patients, essentially left main stenosis, severe 3-vessel coronary artery disease, especially in diabetics, age 60 or above with a high Centex score, acute coronary syndromes, mechanical complications of myocardial infarction, other cardiac surgery at the time when you're doing your valvular surgery if there's associated coronary artery disease. And the objective is relief of angina and perhaps survival benefit. So if you look at the history and evolution of CABG, it started with the beating heart approach, and one of the first people who did this was Arthur Weinberg, a Canadian surgeon in 1946. He implanted the lima directly into the myocardium. Kolosov in 1964, who's a Soviet surgeon, used the lima to the LAD on a beating heart. So this is now 80 years old. The story began a long time ago. And then the arrested heart came along with the development of John Gibbons' cardiopulmonary bypass machine. Michael DeBakey used the saphenous vein graft. Favaloro at the Cleveland Clinic used the saphenous vein graft. And Alan Carpentier in 1971 was the first who started using the radial artery, but it was given up because angiographically it occluded. Interestingly, when the same patients were studied in 1990s, those radial grafts that were occluded in the 70s were found to be open. And I think it was because of spasm in the radial artery in the 70s that caused the issue. So if you look at the grafts that I used, we've talked about it extensively up until now. The saphenous vein graft, the lima, rima, bema, radial artery, gastroepiploic artery. And this is the standard operation that is, we all know the way we know it. Now, the CABG has a good outcome. The standard operation has a good outcome, and at the need for redo surgery is only 3% at 5 years, about 10% at 10 years, and a quarter of your patients will come back at 20 years. So it's a fairly good, long-lasting operation. Now, what is the mechanism for recurrent ischemia? There could be new disease in vessels that were not previously bypassed because they did not have that degree of stenosis. Progressive disease in native vessels beyond the graft anastomosis because good secondary prevention was not put in place. But most importantly, disease in the bypass conduits themselves. And this is what the vein grafts are. If you look at vein graft failure rate, it is 8% at 1 year, about 40% at 5 years. Half of the vein grafts occlude in 10 years, and about 3/4 will occlude in 15 years. Also associated with this is silent graft occlusion, and that occurs in about 30% at 1 to 3 years, 28%, 32% 4 to 6 years, and 35% at 7 to 11 years. So there is quite clearly an attrition rate in the vein grafts. Now, what is the mechanism of vein graft failure? The veins are not they were not intended by nature to take care of high pressures. And so there is a problem. Early, there is a thrombosis. In an intermediate phase, there's intermittent hyperplasia. And late, there is atherosclerosis. And if you take a section of these vein grafts, this is what they look like when they fail. So with that background, let's talk about arterial grafts now, which is the main topic of contention today. Arterial grafts, the internal mammary artery, at 10 years has a more than 95% patency rate. And this was shown by Loop et al. From the Cleveland Clinic. He also showed the long-term prognostic benefits of Lima to the LAD. The graft patency for arterial conduits is 97% at 1 year, about more than 90% at 5, 10, and 20 years. So it's a very good graft to put in. And this is a picture of graft, Lima to the LAD, picture taken courtesy from Dr. Shahab's presentation, who's sitting over here. So this is a great Lima to the LAD, which was put in more than 10 years ago. And if you look at it, it's the anastomotic site is great, the runoff is great, and the LAD looks okay. But like it's being talked about right now, if you look at just simple vein grafts versus one internal mammary artery, and you look at patient survival at 10 years, then there is a greater mortality with patients with just vein grafts as compared to internal mammary artery, one internal mammary artery that was used. So the question that begs an answer is, why not have MAG and total arterial grafts, MAG or TAG, whatever you may call it, MAR or TAR, whatever. The prevalence of MAG use, as has been described by previous speakers, in the STS database is out of about 1.5 million patients, they had 11.3% with a range of 9.9 to 27.8% MAG use. European data seems to suggest that the use is about 4 to 17%. So it's still a very low number of patients who get more than one arterial graft. And this has been talked about, the various configurations in which you can use. The first one is the standard graft, 2 veins and a Lima. Then you have 2 internal mammary arteries. Then you have 2 internal mammary arteries, 2 radial arteries, and then a combination thereof. Now, this is a systematic review with meta-analysis looking at total arterial coronary artery bypass graft surgery is associated with better long-term survival in patients with multi-vessel coronary artery disease. This is a recent meta-analysis. And if you look at this plot, most of the studies that have been done seem to suggest that the survival benefit is in favor of total arterial revascularization. Meta-analysis for the combined cohort found a significant survival advantage for TAR by both random effect and fixed effect models. Now this is comparing the blue one, this is survival. If you just choose a Lima, a single arterial graft, which is red, the survival is less compared to somebody with multiple arterial grafts. The trouble, though, is that up to 10 years, the grafts really do not diverge a lot. But after 10 years, the disparity increases. So what is the evidence and what is the problem with the evidence? It's no longer acceptable just to talk about evidence. MAG-TAG may be associated with improved survival, greater graft patency, freedom from reintervention. However, the critique is that the level of evidence, and there are flaws in that evidence. Most of it is retrospective analysis of data, and we all know that we select our patients for MAG, and I think that contributes to it as well. The patient population that we tend to put MAG on is a younger population, so the outcome is going to be good anyways. So I think if we take away those biases and do a prospective randomized controlled trial, that may be the best evidence that you will have. And we'll talk about that in a few minutes. So what are the reasons for slow adaptation of the MAG and TAG? I think, like I said, it's the evidence. People are not comfortable with the evidence, the expertise that has been talked about this morning, and also Ali talked about the incentive. So what is the incentive to the operating team to use more than one graft? So this is a study that was done in the UK, and it was a survey. Why do UK cardiac surgeons not perform their first choice operation for coronary bypass grafts? So the first question was, is there any evidence to show an advantage of MAG? This was asked from consultant surgeons, and these were the responses. 9% said there's no advantage, or there's no evidence. 52% believe there was circumstantial evidence, and only 40% believe that there was true evidence to support a MAG. Second question was, what percentage of your patients might benefit from multiple arterial grafts? And 44% said that only less than 25% of my patients will benefit. 27% believed that the patients, 25 to 50%, they had patients who would benefit, and about 30% felt that more than 50% of their patients would benefit from the multiple arterial graft strategy. The third question was, if you required elective CABG tomorrow and had typical 3-vessel disease and reasonable LVEF, what would you wish to have? So the responses were equal between the the choices given. Whatever the surgeon decides, IMA and 2 veins, 2 IMAs and 1 vein, and 3 arterial grafts. Mind you, this is a surgeon replying, this is a surgeon's choice. And only 23% are saying that they would want to have multiple arterial grafts. And the last question was, multiple arterial grafts are not performed commonly in the USA and the UK because there is no proof of benefit. 20 respondents said that. The mortality may be higher, about 50-50. The procedure may take too long, is what the majority felt. And we talked about the learning curve. A lot of people felt that there would be a learning curve. So what can be the strategies to increase MAG or TAG? I think the time has come for specialist coronary operation teams, centers, and for this to be recognized as a separate specialty, where targeted referrals can be sent, and you need to include multiple arterial grafts in CABG benchmarks. If you do not do that, then you need to have a benchmark, and you need to look at centers who are doing more than 1 grafts. And this is a pictorial diagram of how you would use measures to increase use of MAG for isolated coronary bypass. You have surgeon champions, you retrain your surgical staff, changes in institutional quality metrics, weekly meetings, evidence-based publications, and then the cycle keeps going on. This is what is called a PDSA cycle, a quality improvement cycle. We did a study about 10 years ago looking at the short-term complications after bilateral internal mammary artery grafting, a retrospective study, modest population, and I think the time has come to look at the follow-up of these patients. And I think I'm going to leave you with this. Currently, the Roma trial is underway. It is a prospective, event-driven, unblinded, randomized, multi-center trial looking at single arterial graft versus multiple arterial grafts. It'll recruit about 4,300 patients, and the primary outcome will be the composite of death from any cause, stroke, post-discharge myocardial infarction, and/or repeat revascularization, and the secondary outcome will be all-cause mortality. This is the Roma trial. Thank you for your attention, and I'll take any questions if there are any.